Welcome to the Education Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsor, Limmer Education, we can make science more accessible and understandable. Hello, everyone, and welcome to the January 2022 Pre-Hospital Care Research Forum Journal Club webinar. My name is Megan Corey, and I am joined by Alex Tremblay, Katie O'Connor, and Dr. Bill Toon. David Page is also with us today, and we are going to examine research entitled, "Do Paramedic Students Have Situational Awareness During High-Fidelity Simulation?" This is a mixed methods pilot study that was published in the International Emergency Nursing Journal in 2021. We're also very lucky today to be joined by the primary author and researcher of this study, Justin Hunter. So Justin is here to share his work and share his experience doing this research and provide us with some advice on future directions for this exciting piece of research. So if you're joining us during the live broadcast, please use the chat to interact and discuss the topics with other participants if you're able to. And the Q&A, the questions area that's directed at the panel members. If you hear something you like also, please quote, tag, or share it on your favorite social media site. Please use hashtag EMS research. And of course, we love it when you tag at PCRF at UCLA, as well as our sponsor. We want to thank our sponsor, Limmer Education, for supporting education research and the furthering of EMS education research and these webinars. So let's begin. We've got Justin Hunter with us, and I'd like to just bring you right in, right at the beginning. Justin, are you Dr. Hunter? I forgot to ask if you're Dr. Hunter yet. I know you're in a doctorate program.
It'll be a few weeks.
My PhD
been successfully defended, so to speak. Just got to cross some T's and dot some I's, but almost.
Great, congratulations
Justin
on that.
Fine,
I'm sorry?
Justin is fine, though, no problem.
Okay, Justin, thanks. I was gonna say, there's no intermediary, but next week we'll call you Dr. Hunter. So congratulations on this published work and on doing some simulation research, which is so critically important right now. For a number of reasons that we can get into as we talk through this with our panelists. But Justin, can you take a minute and just introduce yourself, your background, and just how you got into research as well? Start with your background.
Sure. Well, I live in Oklahoma right now, but my career got started in Florida, in the Tampa Bay area, where I was a firefighter paramedic on an engine for 7 or 8 years, and I always wanted to move to the sunny beaches of Oklahoma. So I moved here. The water's a little redder here, the dirt's a little redder, and there's more tornadoes, but I certainly love it. So I've been here in Oklahoma for about the last 10 years and do, like everybody in EMS, I got 78 jobs. I have worked for some of the EMS agencies around and worked as a flight paramedic for several different services. But through all that, I've worked my way up as faculty member at Oklahoma State University's paramedic program here in Oklahoma City, from lab instructor and part-time all the way up to tenured faculty now, and also the paramedic program director. So we have a very big program with a lot of students, and we're lucky. I know most programs don't have the resources because it's hard to get a paramedic program going anyway. We are lucky at our program to be able to have some resources and support from our administration to be able to do research. Like you said, I'm done with my doctorate. It's just not official yet, but I just completed almost 5.5 years through Monash University in Melbourne, Australia, with Professor Williams, who's another one of the authors on this paper. And I also am the founder and run a nonprofit called EMS Success. You guys can find that on the internet at emssuccess.org. And our main mission, it's a nonprofit, like I said, is to provide financial assistance to EMTs and paramedics around the country. And the #1 way we do that is by providing scholarships to paramedics who then go and work in rural America to pay back their scholarship. And so it's just a way of keeping paramedics out in the rural parts of the country. That's been pretty successful for about the last 10 years. Why did I get into a research? I still work on an ambulance. I still run calls. And just like everybody that's probably listening on this broadcast right now, we see bad things happen. And bad things are always going to happen. And that's part of the learning process, I suppose. And but the longer you start doing this, the more you start to realize how outcomes or bad outcomes are preventable. How taking somebody to the wrong hospital can have an impact on a patient. How not knowing the difference between a medication that somebody may have overdosed on, or what somebody's pulse ox was while you were intubating them, not noticing that it dropped. And these things have everlasting effects on our patients. And I am a big believer in we learn by making mistakes. This is true. This is definitely true. But I feel like healthcare, not just EMS, but healthcare is really one of the only professions that I know of where, we can make a mistake that kills somebody, and everybody seems to be okay with it. So I know I'm pretty blunt with the way that I say that, but we make mistakes, and sometimes patients die because of that. And as long as we're always usually taught, well, as long as we learn from it and don't make the same mistake again, well, then we're doing okay. I just don't think that that's good enough. I don't. I know Dave Page, who might still be listening, he used to say something years ago. He probably still talks about it with crew resource management related to aviation. And if our pilots learned by crashing the planes and killing the passengers, we wouldn't be okay with that. We wouldn't say, well, he learned his mistake with that bad flight and a couple hundred people died. I hope he does better in the future. And so I think a lot of those same principles can be applied to what we do in paramedicine and out in the streets. And so when I started getting into research, it was all about crew resource management. And the more I learned about crew resource management, there's lots of components to it: leadership, communication, teamwork, all kinds of things. But the one that really stood out to me was the component of situational awareness. And the more I studied it and the more I learned about it, the more I learned that we don't know anything about it. We think we do, but we don't. And so this was the third paper in my thesis to be published, but the first paper was a scoping review that was titled, "What is Known About Situational Awareness in Paramedicine?" And to make it really short and sweet, nothing is known. We don't know anything. We use the term it's poorly defined, it's poorly understood, and we don't use the term correctly. And so why am I in this research, and where does it come from? It comes from identifying that situational awareness is poorly understood and trying to learn as much about it as possible, so that if we can improve the situational awareness of our paramedics and EMTs, that we can reduce medical errors, we can reduce human errors that ultimately lead to bad outcomes for patients. That's it in a nutshell.
That's great. So you mentioned you did 3 papers. Your first one was a scoping review. What was the second one then?
So the second one, which I will definitely talk about a little bit today, was a theoretical. We've actually done 5 papers, and so the one we're talking about now is number 3. But number 2 was a theoretical framework. And so you mentioned other program directors may be listening or being a part of this or motivated by it. And I'd probably say that was one of the biggest lessons I learned throughout my research at Monash University, is the importance of theory and how we can't just go out there and measure things just because we want to measure them. If it comes down to decision making or behaviors, the theory is important. And the theory of situational awareness has been proven in other industries to be a cognitive psychological theory. And so the second paper was all about exploring what other theoretical models of situational awareness exist in other industries, and which one would be most appropriate to be applied to paramedicine. And the one that we all determined as authors for that second paper was originally published back in 1989 by a lady named Micah Ensley, who's kind of the godmother of situational awareness in commercial aviation. Yeah, there's that's the theoretical.
Yeah, we couldn't have practiced this better. But
Yeah.
right when you said that, I thought, oh, this is perfect. We have the second slide, which is this one, which we can dive into a little bit. So this was a part of your, I'm really glad to hear you mention theory, because one of the things that happens too when you in education, when we're teaching, even in simulation, you know, we're running a simulation. A lot of the structure of a simulation is really supported by education theory throughout, and different ones. So we can talk about that when we get to different elements of your research here, because we do want to ask about different, you know, what theories, you know, supported certain aspects. For example, different models of debriefing and things like that.
Absolutely.
So that leads us to this question. So if you are, and again, you answered something that I was thinking of too, with the program directors out there who might be thinking, you know, I'd like to do some research, but I just don't have the time. And so that is commonly what we think, is we just don't have the time. So I'm glad to hear, you know, it is possible. This is sort of hope for program directors. And in particular, if you have something very specific and tight that you want to run inside your program and then take it to an abstract submission, or a publication or sharing, that can just expand your involvement in research. So if you can walk us through, you know, for people out there that maybe are just getting into the different theories, you know, different ways to apply theory, and you landed on this Ensley 3-level theoretical framework. A lot of times, you know, this can bring back sort of graduate school anxiety, looking at bubbles and arrows and everything. Can you walk us through this this theoretical framework?
Sure, I can try.
Yeah.
So yeah, the making sure that it's the most up-to-date one, but yeah, that certainly looks appropriate to me. And so the theory that you see there is adapted from Micah Ensley's. It's actually all of the same components, but we just rearranged them a little bit to make them a little bit easier to read and a little more focus on what the biggest element of this model is. And it's going to be the one that you see on the top left there that says situational awareness, that has those 3 levels. And so without getting too far into the weeds, why is this the model that we chose? And so there's about 7 or 8 models out there, but we really looked in depth at 3 of them. And all of the other models, to sum it up pretty shortly, is to say that situational awareness, the other models say this, that you can't be situationally aware if you have a bad outcome. And that's the way that I interpreted them as the more I got into researching them. And so if you're flying a plane and you don't see the thunderstorm up ahead, that you're going to have a bad outcome, it's going to cause problems, and you're not situationally aware. And so part of that comes back into that feedback loop that you see, that big line coming from the right, from decision making and execution all the way back over to situational awareness. What I liked about this model, the biggest thing is that the situational awareness is separate from all of these other factors. And so there's a lot of those words are really small, but we have education and experience and training, stress. Stress is such a big one. Decision making and execution and actually processing information. All of these things affect situational awareness, but they don't account for whether or not somebody is or is not situationally aware at a given moment. And so that is the main reason why we went with this. And so I don't know if you can zoom in at all, but if the 3 levels that you see there, all 3 of those levels would have to exist with any situation or any topic in order to be situationally aware. Going back to that first paper that I told you about, where we concluded that we don't know anything about situational awareness, and the main reason is because the publications that exist on situational awareness in paramedicine across the world, whether it's empirical or gray literature, talks about situational awareness in terms of just a safety issue. I'm walking into a home and I need to make sure that, there's not a bad guy in the closet who's going to jump out and hit me with a baseball bat. And if I don't check the closet, then I'm not situationally aware. That's the way I was taught. That's what's in our textbooks. It's very vague. It's very basic, and it doesn't go into theory or any of the published data on situational awareness at all. And those of you that are educators, there's a lot of experience with stuff that makes its way into our profession and into our textbooks that has no science behind it. And we just did it that way because, that's the way we started. But now times are changing and science is changing things. So what actually is the definition of situational awareness? It's those three bubbles that you see there. And so I give you an example. The three levels there say recognition, interpretation, and prediction. I have a little model here in paper number 5 that we published called the Rest in Peace tool, which goes along with those. But nonetheless, recognition, interpretation, and prediction. And so to give you a clinical example of why that's important above and beyond just maybe scene safety would be something like end-tidal CO2. That's probably the best way to talk about it. And so the first one is recognition. And so if you are, let's say we have a septic patient and it's hard to diagnose sepsis out in the field, it really is. And really over the last 4 or 5 years, the big publications have told us that having a low end-tidal CO2 can be correlated with a metabolic acidosis and possibly leading to sepsis, right? And so that's starting to become a big factor. And if we don't have that pre-hospitally, it's hard to identify somebody who's septic, and then we don't make the pre-alert call, and then the hospital is delayed and they don't get their antibiotics for another hour or two, which affects patient outcomes, right? So the first one there is recognition. And so if a paramedic doesn't even put the end-tidal CO2 on the patient, or if they put the end-tidal CO2 on and they don't know that they don't even know what the number is, then they are not situationally aware because they haven't even recognized the number. Pretty simple. And that's a lot what that kind of goes with what a lot of what we thought the definition was. But there's 2 more levels that are arguably more complex and a little bit more important. The second part is interpretation. A paramedic could put end-tidal CO2 on a suspected sepsis patient all day long, and if the number pops up and says 26, and they don't know what that means, they're just, well, it's 26. I know that in the textbook it's supposed to be 35 to 45, but it's 26. I don't know, is that good or bad? I don't know. If they don't know what that means, then they haven't properly interpreted it, even though they see it. Even though they saw it, they know there's a number there. They don't know what it means, then they're not situationally aware, okay? The third one is probably the more difficult one to actually accomplish. Experience probably plays more of a role in it, and it's prediction. And so using the same scenario, paramedic puts the end-tidal CO2 on. They've read a new protocol that says, pay attention to the number, and if the number is less than 28, call a sepsis alert, or be cognizant of possible sepsis or something like that. But if they can't predict that this patient is now so close to dying or going into irreversible shock or MODS because they are so far into sepsis, then again, they're still not situationally aware. I put the end-tidal CO2 on. I know what the number is. I know that means it's bad, but I'm not tying that to this patient could die because they don't get their antibiotics as quickly as they're supposed to, right? So without all 3 of those, then somebody is not situationally aware. And
there might even be an intermediary in there too, when you have a student that can, they remember to apply a capnography, they forget to read it, but later when prompted in the debrief, tell me about the capnography, they
Yeah,
would say, I recognize I put it on, but I forgot to actually read it. And I know that that would have been important in XYZ. So that
absolutely.
maybe gets at cognitive load or something like that
But you know
inside of there.
what's even crazier is that paramedics do the same thing out in the field. Paper
Yeah.
number paper 5 has not been published yet, but paper number
Mhm.
5 was a prospective situational awareness study using the same Sagitt tools, which we'll talk about in a minute, and this theory on 911 calls in Oklahoma City. And it is a study that took place over 3 or 4 months and hundreds of 911 calls. And you know what we found? The same exact thing.
Yeah.
Put
So,
CO2
so
on,
you know what?
and I ask you, what's the CO2? And they say, I don't know what the CO2 is.
Yeah, I was
Yeah.
going to say from a quality assurance perspective here at our agency, that very common in reviews of, you guys did this 12 lead. What did the 12 lead show, or what did the Untitled show? And they're like, well, we did it because the guideline said so, but we didn't think that's what was wrong. Well, it's in the guideline for a reason, right? So.
Right. Think of the paramedics that are sitting here listening to this. We've all done it. I know I've done it. I've been sitting there in the truck after I've transported the patient and looked at my partner and said, what was his glucose again? What was it? I don't even know it. I've already transferred care of the patient over to the hospital, and I'm trying to get somebody else to recall what the vitals were or what this was or something like that.
Yeah. Katie, do you have something to add?
Yeah, well, this is like conversation is kind of a question that we're getting from the audience here from Mike Faircast. He's wondering if, and you just pulled up this slide, do you guys think it has anything to do with the way that we train and the idea of even just like thinking about to field that EMS is so checkbox driven?
Yes.
So when you think of the older National Registry style skill sheets where it's just like, did you check PSI scene safety? Yes, check the box. But even in our like electronic healthcare records now, it's like GCS, you just have to do a drop down menu and it's a required NEMSIS field. Like, do you guys think that has anything to do with this? Instead of looking at it, what you're assessing here is global, right? Like you're looking at global things, not like I did one step, I check and I get my 42 points.
Singing our song, Mike.
What a great question, and it's probably not going to turn out the way that the whoever asked that question would think. It's actually the opposite of what you think. Yes, we're checkbox driven on sheets like this, but that's because we don't have enough formative training with the right type of checklist. And so there isn't, I don't know of a checklist that exists that says, what was the guy's end-tidal CO2? It may be on the report afterwards, but one of the conclusions that we found, because this was a mixed method study, and so that means we're collecting the data and we are measuring whether or not these people are situationally aware. But the mixed methods part, the qualitative part that comes after, is trying to determine why they weren't situationally aware. And some of the big reasons were using thematic analysis, which is an absolute nightmare, but it's necessary, is that the students are stressed and they lack an organized approach to either documenting their questions or following the right questions. And so when somebody, do I put an end-tidal CO2 on or not, it's all from memory. And so we are checklist driven in terms of registry skills, but we are not checklist driven in terms of actual patient care. And I believe that we should be more. People say, and to give you a great example, which we talk about heavily in some of my other presentations, is commercial aviation. You see this checklist that we see here is about an out-of-hospital scenario, but commercial pilots have checklists as well. And almost every checklist that they have, especially if it's an emergency checklist that would be in their QRH or otherwise known as a quick reference handbook, they may have to memorize the first couple parts of it, but the rest of it, they are expected to open up the book and go through their checklist, because there's so much at stake if they miss one step. If you miss one step, that plane's going to crash, and they can do it when they're under more pressure with less time than us. So we should be able to use our checklists and create new checklists, which is steps down the road, to improve our situational awareness and make sure that we're not missing things.
Well, I think I want to dive into the research itself and get into the mixed methods here. See, look at your tools, and then let's get into that book recommendation. In case I'm sure you've read it, if you're talking checklists, is a Checklist Manifesto, a terrific book by Atul Gawande. And one of the big things is he talks about airline checklists, but he also mentions that checklists are fluid. They're not static. They don't stay the same for 5 years and 10 years. They're fluid, and they're developed consistently over time with experience. And one of my favorite ones is the one that starts with fly the plane. That's on a checklist. Fly the plane, which means there has to be something behind that. You can't just, that's not a task oriented thing. That's a high level critical thinking thing. You got to know how to fly a plane to follow that one. It's a reminder to fly the plane so they don't get too embedded in their checklist. Absolutely. So I love that part of that book.
And that official aviation checklist goes aviate, navigate, communicate. When all else fails, fly the plane first.
Yeah. So let's talk about the mixed methods nature. I love mixed method studies, by the way. I'm a huge fan of them. You did qualitative and quantitative and qualitative. And the quantitative tools that you used to evaluate situational awareness were the integrated out-of-hospital scenario, which we're familiar with the elements of the integrated out-of-hospital scenario. And then tell us about the situational awareness global assessment technique. And I keep wanting to say tool, but it's not really a tool, it's a technique. So tell me about this.
It's a technique, and so I call it the Sagitt, and well, I don't call it the Sagitt. It's been published as the Sagitt. I have to back off of my Bob Saget jokes every time that I have a presentation. Bob passed away a couple weeks ago, but nonetheless, it is called the Sagitt Tool or Sagitt technique, and I use them synonymous, but it really is more of a technique. And basically, it stands for Situational Awareness Global Assessment Technique, and it's a technique that the authors, well, it doesn't matter whether or not you're publishing a paper, that the proctors of a given simulation would create in order to measure somebody's situational awareness during a simulation. Or, as we did in paper number 5, which nobody's ever done in the world, in real life during actual emergencies. And so basically what you're going to do is you're going to, that Sagitt is tied to the level 1, 2, and 3 of the situational awareness model that we were looking at earlier. And so during a simulation, if you have a 15-minute simulation that you have created with your students or with your employees at an EMS agency, you would get a group of people together to review the scenario that you've created. And then you are going to stage predetermined freezes or stops throughout the simulation. So they can be 3 minutes down the road, they can be 6 minutes down the road, whatever. You're going to let the scenario play out, and then you're going to stop the scenario. You stop the scenario and you quickly ask whoever it is that you're wanting to measure their situational awareness. If it's the team leader, you ask them predetermined questions that you have put into this Sagitt that are tied to level 1, level 2, and level 3 questions. And so the questions are always the same for this given scenario. You're not going to ask the next paramedic who goes through a different set of questions. Not in a simulation. In real world, you do have to ask different questions because you don't know the simulation because it's real world, right? And so an example would be you'd stop them and say, what's the patient's blood pressure? What's the patient's skin color? Or you could also say, what can you interpret from the patient's heart rate? What do you think this patient is going to need 1 hour from now? And so you actually watch how that might progress, because we don't know all that stuff right at the beginning. Maybe it takes us 10 minutes to get that information from a patient, but nonetheless, we still measure it and try to look for trends to see how people do. It's stressful. It's a stressful situation. And a lot of people, the number one thing that people come up with when they read it is that has to screw up the quality of the scenario. If you're telling me that I'm going to stop the scenario and ask these questions, it's got to have an effect. Well, There's been multiple publications that has proven that that is actually not the case. It kind of goes back and forth when it comes to commercial aviation, nuclear power, offshore oil drilling, things like that. They've shown that stopping the simulation in the middle does not affect the quality of the scenario or change their questions or change their level of treatment or anything like that. In healthcare, there was actually a situational awareness study that was done similar to this in an operating room. And in that case, the surgeons thought that it did affect, and everybody else, the nurses and the techs, did not think that it affected it. But that was just one study. So it does kind of go both ways. But in this study, the students mentioned that they did not feel like it affected their treatment plans with the scenario or how the scenario was going to play out.
That's a good point. So I didn't quite catch that when I read it the first time. So when you're running, you had 12 students that were in this study, 2 days, right? 6 students on one day, 6 on another, 2 simulations, 1 on each day, a sepsis simulation and an anaphylaxis simulation, response to a medication, I believe. Did I describe that right?
Yes, that's correct. And so when I talk about the freezes, in this particular scenario, we didn't do the freezes. We did 1 freeze. So you can normally do up anywhere from 1 to 3 to 4 to 5, and we chose to go with 1 because it was our pilot study. And so this was the first study done like this in paramedicine, and it's already as complicated as it could possibly be, being a mixed method study. And so we went with just 1 freeze as opposed to multiple. Papers 4 and papers 5, there were 3 or 4 freezes during those scenarios or real life situations, but in this case we just did 1. But the published studies say multiple is going to give better results, at least in commercial aviation and industries like that.
So in this table here, we had the integrated out of hospital scenario, which is the first quantitative piece. And then in this scenario here, or in this table here, you're looking at the Sagitt. That is done afterwards, right? Is that evaluated afterwards, or are these questions that were
in this simulation? It was done after, but it should be done during the scenario. You get better results if you stop it during the scenario as opposed to just doing it once. Having multiple stops throughout is going to yield better results, and that's what we did with subsequent studies, but not this one. This one we waited till the end. I think our biggest concern was the stress on the students. And so for other people that are listening about wanting to do research with your students, there's a lot of curveballs that come in terms of getting an ethics or an IRB to approve it. And one of the biggest questions is stress, right? And that really would be for any research study, stress. But students, the problem is that these are my students. And so there had to be an understanding and enough explanatory efforts taking place for them to understand that this was separate from grading, this was separate from their progress in the course, and that this was not going to affect their ability to pass a class or anything like that. And so it has to be voluntary. Not everybody agreed that was in the class, and they have to be able to drop out if they want to drop out. That has to be a part of the consent process. And they just have to be fully aware of everything that's going on and why you're doing the research and what it is what the questions are that you're trying to explore with your research.
Yeah, and I think one of the things, so these are the quantitative, and this one is quantitative because you have categorical variables, they either did it or they didn't, they either got it right or not, these questions. This is, and it's you're really testing clinical reasoning, right, and higher level cognitive domain things, but you could apply this to other things too, up to affective or even psychomotor. And actually, I don't know if people out there have already read the Airway Compendium or checked it out, but the education article, the NAEMSP position statements on airway management, there's the training and education article that goes through this, not just deliberate practice of the procedural skill, but also the clinical reasoning approach that goes with it, as part of a call to changing our education. And Artsia has something in here, I think that's also, and I'd like to bring in Bill Toon on this question, because he always, comments on this. So Bill, if you're able to comment on this, and maybe Katie, I see you're coming off camera here too. Art had said, thank goodness the practical exam is sunsetting, but will program educators be able to evaluate at this level? So there's not just a need for research, but there's a need for collaboration among educators about how we're going to do this. And I think Justin comments on something that's really important, and that's the leveling of simulation. For formative simulations and teaching in simulations, you may be more likely to, and is it good practice to have stopping points at particular areas and do corrections, or allow students to self-correct, right? Allow the student to actually self-correct. And then as they get more and more, used to running these things and more knowledgeable and competent, approaching competency or advanced competency, they can actually, you have fewer interruption points. So I'd like to ask, Katie, what do you think about that? And then Bill Toon too, I'd like to hear from you on this, because you always talk about educator preparedness.
Yeah, I think Art's question goes great too with Bruce is talking about asking if we could talk about the value of interrupting versus like waiting until the simulation's ended. And from the simulation literature, if you're looking for this, a lot of it's called like rapid cycle deliberate practice, type of debriefing. So it's this idea of you're rapidly cycling through. You could do it with like rewind points is what they typically do, is the cycling, but you could also just do it with pauses and formative assessment. And if we think about it too, sometimes we get real concerned about, are we debriefing, are we giving feedback? But in our learners, which is, this group is still learners, I argue that new paramedics are still learners too, right? Like we're still trying to get better, but maybe the feedback is the most important thing. And so we're seeing it, especially there's a lot of research around codes and code teams and how you can improve CPR. And if we think about like an ACLS scenario, right? Like the most important stuff is the actual compressions, but you start the compressions at the beginning, it kind of runs all the way through. We get to the end, we have 1,000 things as educators we want to chat about, like you didn't have sharp safety, or you did the wrong dose of atropine, or really we should have shocked earlier. What was really important? Was it the compressions? Like that was what was going to make a difference in the patient outcome. So sometimes I think when we, especially are talking about paramedics and advanced life support, we forget what's the outcome or the importance of the scenario.
But doesn't that just get at the proper, again, education on how to run a simulation, pre-briefing, having objectives for that simulation? You could literally run that same simulation and have different objectives for it. You could run a cardiac arrest from day one, because they all come in with CPR, right? So you could run a cardiac arrest, but your expectations and your objectives are different than that same cardiac arrest 6 months later, or even 6 months later after that, or even when you're doing continuing professional education. You may have affective outcomes that you're looking for, like did they clean the scene? Did they talk to the family? Did they provide, a death notification, counseling, and communications? And there's pearls for all of that. There's research behind all of that. So yeah, we could. Bill Toon, are you in there? You gonna pop in here with us?
One thing that I wanted to clarify: when we stop to do a freeze. And like I said, we've continued to do this and published after this, where we're stopping in the middle of the scenario. There is no feedback given. There is no clinical investigation given. The stops last about 20 seconds. And it's, all right, everybody stop. Joe, what's the blood pressure? What can you interpret from his heart rate? What do you think this guy's going to need an hour from now? What medications was he allergic to? Okay, continue. That's it. There's no explain to me what it has nothing to do with wanting to determine whether or not the student is doing well or not, or providing any type of feedback back to the student. It's just quickly documenting where their brain is at that time and then moving on.
Bill?
Thanks, and Justin, thanks. I really liked reading this paper and hearing about the other papers, so it gives me something really to look forward to. You touched, Megan, on a key thing, and when I heard it very back at the beginning, how many instructors really know the theory of what we're doing, no matter what it is? And I was sitting here and even thinking about it, and I think about the amount of education that's needed for someone to teach kindergarten versus what we need to be able to teach someone to do life-saving skills as a EMS provider. And I don't care what level it is. And I've used this term before, is that we often do our education on the cheap. How quickly can we get it done? How quickly can we get them through the pipeline? How quickly can we get them out in the field? And did they pass the test? There's no outcome measures with any of that. We just want to see how quickly we can get it all done. And I think that in the long run, we hurt the patient is really what it boils down to. And I go back to when I completed my initial ALS training, which was back in 1978, there was no internship in the field because there was no providers in the field. We were the first. And it was a lot of on-the-job training, and just some of the things you talked about as I read through those stop questions, and boy, how we had to self-learn that stuff. Well, this isn't 1978 anymore. This is 2022. Don't you think we ought to be doing this all better? And I do think many instructors do some stuff that they don't realize that what they're doing is based in theory. This feels right, this makes sense, and it works. But they don't you couldn't ask them, why does it work? What do you base it upon? Because they've never had that depth of experience. And there's two things that I always think about. Airway management, I think that when we look back at the studies that were done on EMS providers and particularly advanced airway management, my argument would be is that we never taught them how to do it properly. Because the people that were teaching it themselves never learned it. And they learned it from someone who never learned it themselves. So we had this perpetuation of poor technique. The other one I hear about is this decision making now is where can a patient go? Can this patient stay at home? Can this patient go to this standalone ED, or do they need to go to the hospital? Show me where in a paramedic curriculum, and there may be some that are doing it, but the common ones don't teach them, okay, you've assessed this, like during the ED time, okay, you've assessed this patient. Did this patient even need to come to an ED? Could they have gone somewhere else? So we should never expect that paramedics don't do a good job determining where people go because we've never taught them that. And there's a lot of stuff, and Justin, you touched on it about the Untitled CO2, and it's one thing to know it's written in a cookbook, and I hate protocols, I have to tell you with a passion. It's in a cookbook, and I had an in-service on it, but they don't do it at all. Versus the next step, they do it, and there's a number and then the final step is what you really look for is, hey, great, look at it. We finally got to this point during the simulation. They put it on, they recognize the number, and they know what they need to do. Then they go out to practice, and the service they work for says, don't use those Untitled CO2 things unless you're absolutely sure they're sick, because they're $10 a piece versus 50 cents for a nasal cannula. And even if you do use it, you go to an ED that has no idea what you're talking about. No clue, and nor is there Untitled CO2 anywhere in that ED. So what kind of reinforcement does that do for us overall? So I'm sorry, I ranted. Goodbye.
No, ladies and gentlemen, Dr. Bill Toon. Okay, so continuing with this then, looking at the qualitative, and I think we lost Justin's camera, but that's okay. Looking at the qualitative components of this, what we're seeing in the two tables, 3.1 and 3.2, we are seeing the examples of the thematic analysis. So for people who are not familiar with qualitative research, what is considered, what are the data from qualitative research? So Justin, can you describe what are the data that you are collecting to get this coding and thematic analysis? Did we lose you, Justin? Are you still there? Oh, I see the there we go. I don't know, we kind of lost the, yeah.
I thought the spooks got me.
Yeah, no, it kind of ended up, I don't know if
What was
we
the
had a
question? You
blip
said something
there.
about data.
Oh, I was just wondering about the quality. We're in the qualitative part of the mixed methods. So when you look at the qualitative, what are the data that you're drawing from? When someone asks you,
Sure.
where do you get all of these themes and,
It's a nightmare.
codes
That's
and
what it
themes?
is.
It
But
is
it's
a nightmare.
it's time consuming, but it's important because without the qualitative portion, and a lot of studies skip it because it's difficult, it's time consuming. There's some people out there that have a distrust of qualitative measures in the first place. But I think it's important because it helps to explain quantitative data. What quantitative data is what is it? Are people's blood pressure going up if they smoke cigarettes? Or are people who smoke cigarettes, do their blood pressure go up? Yes or no? That's a quantitative measurement. But a qualitative would be doing interviews and searching for themes and having long interviews and what we call thematic analysis to search for themes to help explain why are people smoking cigarettes that increases their blood pressure. It's kind of a crash course on it. And so that's what we did in this case. And so we measured the situational awareness using the Sagitt technique. Quantitative measures, we didn't do any advanced statistics or anything like that. It was all descriptive in this particular paper. But then we did follow-up interviews with every single one of the students. And I know that 12 is not that big a number, but a 45-minute interview transcribed onto paper times 12 students is a lot of work to go through. And so basically what you're doing is you have a preset questions that you're going to ask following your quantitative data collection. And in this case, it might have been questions of we're gonna replay the video because these students all wore point of view cameras directly on their head so that we could then replay the video for them and ask them these predetermined questions. And so we would stop at certain points and say, at this point, you had not put the end tidal CO2 on yet. Tell me what your thoughts are on why you didn't do it yet. Or at this point, the patient, they said that they had chest pain, but you hadn't initiated any form of treatment yet. Tell me where your brain was. Tell me what you were thinking. And the further you go into it, the students they become so cathartic and they just start spilling their guts and saying that it was because of this, or I felt this way, I felt this way. And you're not really analyzing any of the data at the moment. You're just recording it because it's so much data. Like my human brain, most of our human brains can't make any sense of it right now. So then you take those videos or audio recording and you get them transcribed by a service, and then they send you a big old giant packet with 100 pieces of paper in it that has transcriptions of all of your interviews and all of your questions and all of their responses. In this case, we had a team, and so it's good to use. It's really necessary to use a team so that it's not just my opinion. So we used 2 additional emergency room physicians who were in their residency, as well as a board certified ER physician, and as well as myself. And so we had all of those people read through all of the transcripts on their own. They make notes of keywords, of themes, of things that they pick up on as, well, I'm sensing a lot of this here. This is what I'm sensing. These are the themes that I'm picking up on, and they start making their own little unofficial notes on their paper and start categorizing items. And this takes a long time, probably several hours for each student. You add that up over 10, 11, 12 students, or if you're doing a whole class of 30 or something, it gets very, very time consuming. Then once everybody's done, you all come together at another session that you would record. If you're going to publish this, that you're going to record and transcribe as well. And then you share all of I don't know what happened to my video. We share all of our themes. And when you share all of your themes, you start to realize, well, we all came up with the same theme. You know, maybe there were 25 themes altogether, but 6, 7, or 8 of them, we all had exactly the same stuff. And when that starts to become saturated, where we keep coming up with the same themes over and over again, we start to identify that as a theme that had an effect on the quantitative data.
And these are things that we commonly, we hear about and see in qualitative research when we talk about how to do this thematic analysis. This confirmation with other coders too really helps. So then what we're looking at right here are the actual themes, the 8 themes that you came down to. And we have a really good point being made by Matt Parrish in here too. Thanks, Matt, for adding some questions in here too, and some with an emphasis on the reasons for having checklists and the brain science and the cognitive load of a person, and not just a student, but a person at any level. And we're going to have different levels of cognitive load, and why we might have checklists versus not. And again, that's why I like the checklist manifesto. It's not a straightforward answer. It's not a yes checklist, no checklist. There's certain things that are more important than others. Med checks, for example, where we already know that's a source of high medical error. So it might be important to have certain elements of that checklist and that's why I think the checklist manifesto is such a great book. But one of the things that I think is the hazard of the checklist is something that you mentioned, and I know if any educator out there read it, they probably laughed and nodded at, and which is where you talked about parroting, where you talked about students narrating and parroting, and we build that in EMT. We build in, I walk in, I say BSI, I say scene safety, and therefore I have exonerated myself from actually doing it because I said it. Of course, we want them to think that up front, but we want them to do that up front, not say it up front. So that's that is the difference. The minute you say to people, you got to stop saying BSI and scene safety, they think you mean, throw it out. It's like, no, I'm not saying throw it out. I'm saying do it. Don't tell me you're doing it. Do it, And so that's why we plant safety things on a scene, When I saw that in the article, I laughed, I underlined, I went, yes, parroting. And of course, all the cameras come on. Go ahead, guys.
I think that the other thing about parroting and checklisting is like provider resistance. And Justin, I'm curious if you had any challenges there. We're currently in the process of rolling out like a medication safety cross-check, which has been very successful. It's reduced our medication errors overall. But the biggest point of contention is that they don't want to say exactly what's on the sheet for fear of it taking away some sort of autonomy. Did you notice anything similar? Is there anything there?
Not necessarily in this one. We certainly did later on. And like I said, there was a couple published tools, reference tools that we created for paper number 5, which paper number 5 was not just measuring situational awareness. It's, can a targeted educational approach improve situational awareness in the field? And so that paper's, I'm dying for it to come out. It's just not there yet. But measuring situational awareness during 911 calls over a period of a couple months, and then provided this training that we are talking about right now, and also implementing a sterile cockpit. So those two things were implemented, specific situational awareness education curriculum, along with a sterile cockpit. And then we went out and ran another 60 or 70 911 calls, and newsflash, their situational awareness was improved. And so, and they used checklists and reference tools in that study on 911 calls. And so there is some stuff that we talk about in that paper related to, there's a stigma in EMS of, while yeah, I know we test them a lot with checklists in school, but there's always been this stigma of you got to memorize everything. If you look up your flip chart and I'm your FTO, I'm gonna bust your chops like there's no tomorrow. Don't look that up. You got to know it. Well, with things like hand heavy and things like the National Registry allowing information to be used during their out of hospital scenario. It's just not reality to think, well, people don't have to memorize the dose of every single little drug. If it's something that I can quickly reference, then we can cognitively offload that and put that over here. And when I need it, I will look it up. And so that stigma is starting to turn. It definitely is. And I think that that's what's led to a lot of the mistakes. So kind of what Megan, you just said about parroting, they do it out in the field. Oh yeah, I did my ABCs. Well, no, you didn't. You just walked in and skipped right over and started asking if they were allergic to anything. You didn't do your ABCs. You didn't actually take 5 seconds to check those 3 things. And so, yeah, when you're looking at these themes right here, I love these themes. 3 of them tie back to the Ensley's theory. So you can see number 5, 6, and 7 tie directly back to the theoretical model of situational awareness. But the ones that we really focused on were those first 3, the lacking an organized approach, because they don't use a checklist, because they don't have any type of mapping to go by, they're just winging it, and getting tunnel vision. And why do they lack an organized approach, and why are they getting tunnel vision? It's because they're stressed. They don't want to make a mistake. It could be they're being tested, they're inexperienced, their heart rate is going through the roof. These things play a role, and it happens to new paramedics out in the field as well. And in commercial aviation, how do we get over that? Everybody has to complete high fidelity simulation in flight simulators before they can ever fly a plane with passengers on it. Mr. I can't remember the gentleman who was just on here, who was ranting and raving, which I loved. He brought up the cheap effect, which is exactly it. What does an airline have to lose if their pilot screws up? Well, they're going to lose hundreds of millions of dollars in lawsuits and lost airfare. So they are going to invest in requiring this, and this before you fly that plane. What does an EMS agency have to lose if a new paramedic misses a Stemi? Not much. I mean, do lawsuits happen that often with stuff like that? To really, maybe it does with Airway, and maybe that's why medical directors are so hardcore on Airway issues, because it's so black and white. Tube was in, tube wasn't in. But what if you just made the wrong decision on, you took the patient to a hospital that didn't have a cath lab, or you didn't realize that the patient was septic and they ended up dying because they didn't get the antibiotics when they needed to? There's no, I don't know if there's the investment there or the incentive there to require the simulation that we really need to make these students competent, or to make providers that are already out in the field competent.
I think that your call for more simulation education and research, I think that was one of the conclusion. Actually, this is just summarizing the 8 themes and the way that you pull them back to the theoretical framework. So those of you doing research, pulling those back into the theoretical framework is really important. But one of my favorite quotes is that when you said we may be able to improve their situational awareness with more simulation and education. So I think that is just a call to arms that we all need to listen to. Katie?
Yeah, I just wanted to say, we talk a lot about aviation industry, but they have time limits on how often you can be up in the air flying a plane, and we don't have that in EMS. So I was wondering if Justin thought mindfulness, stress, anything was impacted by the fact that we're asking people to be situationally aware at hour 49 during a pandemic where everybody's dying and we don't really care, just get back to work for minimum wage. What your thoughts on situational awareness?
Yeah, that's a good question. I have to acknowledge that it probably plays a role in this particular scenario. I don't know whether the students have been up for 48 hours running calls at their agencies or not, but I have to believe that it plays a role, because it's been proven in the trucking industry and the aviation industry and all kinds of other industries that it certainly plays a role. But like I said, what's the incentive to care about working too long? I don't know if it's there. And sometimes some of that comes from regulation, some of it comes from lawsuits, some of it comes from whatever. That's beyond the scope of what I'm researching, but I gotta imagine that it plays a role for sure.
We always have some great little feedback right at the top of the hour when we have to end this great discussion, but we definitely want to continue some more discussion on topics like this, and we want to congratulate you for your research. We do have a comment from Matt Parrish that EMS agencies insulate their liability by following checklists in the form of evidence-based protocols. Overconfident. There's a comment about the quote overconfident, known by the subject or categorized by the evaluator. So did the evaluator, call them overconfident? I don't know if that is something you can answer.
Well, this study also included pre and post assessments by the students. So they would evaluate.
Oh, that's right. They did their. That's right. They evaluated
themselves at the beginning. And they didn't know about the situational awareness model. We asked, how well do you think you are able to recognize events? How well do you think you're able to interpret? And they were all 4s and 5s, and afterward they were all 1s and 2s, or somewhere close to that. It wasn't statistically significant, so we didn't even do the statistics on it. But we certainly could sense the theme of, well, man, I thought I knew what I was doing, but maybe I don't, when it comes to situational awareness.
Yeah.
So I certainly think that the simulation itself plays a role in improving their situational awareness. The research study itself opened their eyes to, well, I know that I know how to run these calls. I know how to pass this class, but I'm not situationally aware. And now I know some of the things that I need to work on.
Great. So we're at the final comment here. Bruce, really appreciate this one. We all recognize this too. Field training equals, quote, forget all that classroom stuff. Let me show you how it's really done. And that's something we can, to be continued. Let's all continue this discussion at a future time. We want to really thank you all for joining us, and congratulations on your research, Justin, and thank you for joining us. We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at www.pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website at www.prehospitalcare.org. A special thank you to our sponsor, Limmer Education, providing education tools for success at every stage of your EMS journey.